Okay, morning ladies and gentlemen, my name is David Kang from Korea. Today I would like to present you the results from a clinical trial comparing the effectiveness of toric foldable iris-fixated phakic IOL implantation. The results of that with a limbal relaxing incision technique to correct moderate to high amounts of myopic astigmatism. Now, as we are all aware, the toric Artiflex, since its introduction, has been known to be effective, predictable, stable, safe, and very efficacious. It is well established in the current literature. And however, during cataract surgery, as we all do every day, LRIs are an easy to follow, very predictable method. And when comparing LRIs with placement of the corneal cataract incision on the steepest axis, there have been published results with more favorable cylinder correction with this technique. So we thought during toric IOL cataract surgery, high cylinder toric IOL implantation achieves better clinical outcomes. Combined surgery of toric IOL implantation and LRIs are effective in patients with high amplitude astigmatism of more than 2.5 diopters. There are currently no clinical study to compare the outcomes between a toric Artiflex phakic IOL with a spherical Artiflex phakic IOL combined with an LRI to correct myopia and additional astigmatism. So, the purpose of this study was to compare corrective amplitude effects of high astigmatism patients, those between 2 to 4 diopters of astigmatism, comparing the toric group with a spherical with an LRI group. It was retrospective in design. The usual exclusion criteria were enforced. We measured horizontal white-to-white, chamber depths, chamber volume, and corneal thickness. Pre and 6 months post-operative results were included. Astigmatism was analyzed by the power vector method and the Alpins method. The Alpins method, we all know, includes a TIA and an SIA with correction index, difference vector, and an index of success. Preoperatively, there were no demographic differences between these two groups for age, sex, sphere cylinder, or white-to-white, and central corneal thickness. At 6 months, there were comparable visual outcomes when we were comparing these two groups. However, for the toric group, 100% had more than 20/25, 97% had better than 20/20. In the LRI group, there was 98% who had better than 20/25, and at 6 months, about 82% had better than 20/20. So visual acuity comparisons were quite comparable. If you see the mean profile graph for the toric and LRI groups, we see at 6 months, the delta cylinder is significantly much higher for the for the toric group, of course. We were correcting 2.17 diopters of cylinder for the toric group and only 1.63. At post-op 6 months, 90% in the toric group had less than 1 diopter of astigmatism left, but for the LRI group, only 43% had less than 1 diopter. Okay. At postoperative 6 months, vector analyses of astigmatism showed better surgically induced astigmatism vector scores, difference vectors, correction indices, and success indices, all favorably for the toric group. Scatter plots of vectors for the toric and LRI groups just shows the residual astigmatism that is all clumped together for the toric IOL group. At 6 months, SIA for the toric group was 3.12, and for the LRI group, only 2.02. So why was this astigmatism undercorrected in the in the limbal relaxing incision group? Probably related to various factors, including improper identification of the steep meridian, incorrect calibration of my blade, oblique positioning of the blade, well, it's related to surgical technique, or peripheral placements of my opposite on-axis incisions. So the take-home message here is these two surgical methods are considerably, they both reduce astigmatism and have comparable visual outcomes at 6 months. However, the toric phakic IOL implantation is more reliable, of course, for moderate to high amounts of astigmatism correction than non-toric phakic IOL implantation with LRIs in this group of myopic astigmats. Thank you very much.